Good day, my name is Dr. Arpia, and I will be discussing the objective assessment intervention of burnout. The following are the outline of my presentation for this day. A quick introduction. The core principles in the practice of lifestyle medicine potentially play a role in preventing, ameliorating physician burnout. The adverse life events of the COVID-19 has already provided healthcare providers the experience of burden and also anguish, the same impact felt by the general population, plus the impact of taking care of a lot of critically ill patients within the hospital and our clinics. The COVID-19 pandemic stopped the conversation about the burnout and wellness. Why is physician wellness vital to address? Because of a new pandemic that is silently turning to the next pandemic of healthcare. I'm talking about the pandemic of physician burnout. The physician burnout is often silent even before the pandemic. It will become less silent as the pandemic resolves. Burnout as an occupational syndrome has already been discussed. Announced by the WHO, it adds burnout in the ICD-11 effective January 2022 as an occupational syndrome, a problem associated with employment rather than individual mental health diagnosis. Self-care is paramount in the discussion. Self-care is an ability of individuals, family, and communities to improve health and to cope with illness and disability with or without the support. The triple aim approach to optimize health systems, enhancing patient experience, improving population health, and reducing costs. The need to expand for a fourth aim, to have a more functional or optimized healthcare system, is needed. That's why in this suggestion, we improve our healthcare by means of improving the work life of healthcare clinicians and staff. As physicians, we know our oath as healthcare providers, and it is already imbued in the modern Hippocratic Oath that I will attend to my own health, well-being, and abilities in order to provide care of the highest standard. This has also been noted that since the modern age, international bodies has already acknowledged the need for physician wellness as a national priority. Burnout, as mentioned in passing in a medical academic publication, was seen as early as 1969 by means of the authorship of Bradley. Burnout was mentioned as proposing a thoughtful work schedule of staff in attempt to avoid staff overwork and subsequent experience of burnout in a community-based youth treatment program. It was not later than 1974 that Herbert Fredenberger coined out the formal definition of burnout. Burnout, to describe the disabling effect seen in illicit drug users, was first used in this situation. He also coined out staff burnout, a gradual emotional depletion of loss of motivation, reduced commitment among the volunteers of their body. Simultaneously, in the 1970s, Christina Malak and colleagues also tackled studies on the emotional arousal on the job and noted the detachment concerns in some employees. They theorized that arousal and strategies to cope are important implicators of professional identity and subsequent behaviors on the go. Defining what burnout is has been difficult in the modern age because of lack of consistent international definitions. Burnout is a physical, emotional, and mental exhaustion caused by long-term involvement in emotional demanding situations. We should also take note of other similar terms: role overload, expectations to others exceed one's ability to perform, role conflict, forced to make a choice about which demand to satisfy. There have been a lot of inconsistencies existing for the definition. North America coins burnout is defined as an occupational phenomenon, work-related syndrome. In the American Physician Association, using the DSM-5, burnout is not included as a diagnosis category. In Sweden, Sweden recognizes burnout on a different definition. It's noted as vital exhaustion. It is otherwise known as a difficulty in life management. Vital exhaustion bears striking resemblance to symptoms of clinical depression. People with vital exhaustion in Sweden are provided with access to care and service, including sick days, disability, and treatment. Another term that is also used in comparison with burnout is overstrain, burnout term used in the Netherlands. Its prevalence in the country is 3 to 7%. Burnout in healthcare has three dimensions: emotional exhaustion, the feeling low in personal accomplishments, the personalization of the patient. Contributing factors of burnout include the following: professional isolation, working with a difficult population, long hours with limited resources, ambiguous success, unreciprocated giving, failure to live up to one's own expectation, and personality variabilities. We should also discuss the difference of burnout and stress. Stress is often characterized as overengagement. Burnout, rather, is characterized as disengagement. Emotions are overactive in stress. Emotions are blunted in burnout. Produces urgency and hyperactivity is seen in stress. Produces helplessness and hopelessness in burnout. There is loss of energy for stress. There's loss of motivation, ideals, and hopes for burnout. The lead to anxiety disorders are often seen in stress. The lead to detachment and depression is seen in burnout. The primary damage is physical for stress. The primary damage for burnout is emotional. You may kill you it may kill you prematurely for stress. It may make your life seem not worth living for burnout. Take note for burnout. There are a lot of imprecisions in the diagnosis for burnout. Is burnout a distinct psychiatric illness or part of a depressive disorder? There is an overlap that makes it difficult. Burnout versus depression. Clinical and theoretical foundation for burnout has been in an overlap with depressive symptoms. Clinical and theoretical foundation for burnout has been questioned as a discrete unified pathological phenomenon. Some core symptoms are noted in burnout that are also strongly associated with depressive symptoms. The study by Schrottfield and Biaki examined the overlap of burnout and depression, concluded that burnout is a form of depression, further argued that job-related burnout leads to depression. The study mentioned used the Malash Burnout Inventory, and this tool does not allow the assessment of emotional exhaustion, depersonalization, and personal accomplishments in other situations outside the job. Symptoms of burnout: emotional exhaustion, feeling low, or personal accomplishments, depersonalization of the patient. So, emotional exhaustion can either be fatigue, insomnia, impaired concentration, somatic symptoms, repeated illness of loss of appetite, anxiety, or depression and anger. Whereas the feeling low of personal accomplishments, you're not happy with what you're doing, the loss of enjoyment, pessimism, sarcasm, isolation, and detachment, especially in the workplace. Finally, depersonalization of the patient shows apathy, irritability, and lack of productivity. In the article, the symptoms of burnout are categorized with either five major symptoms. So for the physical symptoms of burnout, often we see the anxiety symptoms or the sympathetic stress symptoms. There often is increase in heart rate, increase in blood pressure, the presence of headaches, restlessness, and nausea. There's also a linkage of physical symptoms related to metabolic syndrome, musculoskeletal pain, dysregulation of hormones, especially in the hypothalamic pituitary axis. It's also noted that burnout among patients with metabolic syndrome is a predictor of hypercholesterolemia and type 2 diabetes. Another symptom for burnout would be affective symptoms. Symptoms on mood. Similarly, symptoms of depression and anxiety are seen. A depressed mood, a changing mood, increase in tension, anxious feelings, irritability, hypersensitivity, and blunted empathy or anger. Oft noted, burnout is also associated with elevated CRP and fibrinogen. Cognitive symptoms for burnout include helplessness, feeling cynical, pessimism, and long-term symptoms for burnout include a decrease in subjective memory, decrease in executive function, and decrease in impaired attention. Behavioral symptoms for burnout include the following: symptoms of emotional outbursts, most of the time in work, medical errors in typing the electronic health records, decline in productivity, and increased turnover in jobs. Physicians are more likely to retire early or change their specialty if they experience burnout. Now, there are a lot of overlaps with psychiatric conditions. That is why it's important for multidisciplinary approach together with a psychiatrist. Chronic fatigue, as mentioned earlier, burnout often feels refreshed after resting, whereas for patients with chronic fatigue, they are more of feeding down most of the day. Burnout is associated with depleted energy and tend to be protected when they are fully recovered or recuperated. Whereas for chronic fatigue, they experience fatigue all throughout the day, even after a good rest. The epidemiology of burnout, as mentioned among physicians, is very alarming. 40 to 54% of physicians have been reported to have at least one symptom of burnout using the MPI tool. Private physicians experience 30% higher risk than those in the academic setting. These data are often coined especially in the COVID-19 pandemic. Only 40.9% of physicians claim to still have time for their families. 14.16% remain neutral regarding the role in the family, and 44.5% disagree and have less time with their family. Burnout exists among physicians with the highest, especially among frontliners, emergency medicine, and primary care providers. Early career physicians experience also higher reports of burnout. This is also evident during the path of becoming a physician, even at medical school. Medical students have higher psychological well-being upon entering medical school. Once in medical school, they suffer from high prevalence of burnout. However, 45 to 56% of medical students have at least one symptom of burnout. This prevalence often increase due to time and due to responsibility and strain in the training, especially when they enter residency. 60% of resident physicians have at least one symptom of burnout. Consequences of physician burnout may be exhibited, including the following. Burnout can be seen on the quality of care of physicians, the job performance, adherence of patient to prescribed management, especially in providing non-pharmacologic interventions, patient satisfaction, mental health issues for physicians, physicians abandoning the field of medicine, litigation and risk of others, right? Litigation risk and many others. An unhealthy work environment can create an enormous human as well as financial cost. In 2018, studies estimate that 4.6 billion in annual costs in the United States are directly related to physician turnover and reduced clinical hours. Systemic etiologic issues in burnout. There is a day-to-day stressor at work in the environment. These are often one of the main issues that would cause burnout in the workplace. The study by Malash and Letter noted that physicians experiencing decreasing sense of intrinsic worth is common in the workplace. Work had often become an obligation rather than a resource for satisfaction that provides the community and support. Medical school call-up of potential future doctors have already been noted to have issues on burnout as well. There is a mismatch in developing between the nature of the job and the nature of the person. Some see it as a job, others see it as a calling. Things physicians lack control of, especially when they are working in the clinics and the hospital. They lack control of the workplace. Increase in administrative and clerical burdens, decrease in flexibility, especially in the schedules, unpaid work time, and also pajama charting, a term that is often used when you bring your work at home. Another thing that physicians lack control of is productivity goals. The physician's internal self will have a problem if they lack the drive to work. So what is pajama charting? Pajama charting has contributed with the erosion of professional and personal boundaries for physicians who have been attributed as a risk for burnout. Lifestyle medicine must stress the need for physician healthcare as a necessary part of patient care. How can physicians take care of others with a full mind and heart if they are constantly running out empty? Being empty provides you no care to your patients. Often we see this, unfortunately, with our senior physician supervisors, often lack empathy and support for medical students who are in training. At the early course of their professional career, medical students are considered experientially failure naive. Once they enter clerkship, they experience reprimands, constant criticisms, and often being pointed out for their mistakes. High risk to feel shame, hurt, and self-blame, and emotionally unable to deal with harshness. These medical students try their best in maintaining high standards, then suddenly experiencing failure leads to an overburden to be better and not to fail in the next time. Some would help. Some would use this to develop healthy coping habits, while others will struggle. These bad experiences and challenges in training often get passed to the next generation of trainees. Self-acceptance. You are good enough. A guiding principle for the ultimate happiness of physicians that must be considered for every doctor. However, accepting less than perfect things is not a part of the culture of medicine. I know perfection is the professional goal of physicians because errors are costly for patient and society. But physicians must know how healthy to respond to stress. The stress response. It could either be a maladaptive response that may lead to greater risk to burnout if responded with a wrongful way. So what are the responses to stress? There is either the increase in cortisol that would lead to blood pressure imbalance, elevated blood pressure, loss of tissue muscles, change in bone density, lower immunity, inflammatory response, and structural changes in the brain. Chronic stress would also lead to the depletion of the volume of the gray matter, including memory. The role of the prefrontal cortex is the inhibition of the brain as well as the limbic system to improve the perception of control over stress and nurturing a healthy coping mechanism. We have a lot of tools that can be used to assess burnout. The following are tools that have been provided in the article. The Malash Burnout Inventory, which it covers three areas: emotional exhaustion and depersonalization, and a low sense of personal accomplishments. It is a 22-item exam or test. The Oldenburg Burnout Inventory is a 16-item test that covers two areas: exhaustion and disengagement. Copenhagen Burnout Inventory is a 19-item tool that focuses on three areas, mainly personal work and client-related burnout. Stanford Professional Fulfillment Index survey covers burnout on work exhaustion and interpersonal disengagement. And the Well-Being Index is a and the Well-Being Index, the purpose is to identify distress in a variety of dimensions. For the risk factor, now, how can we tackle management for burnout? We must first consider risk factor prevention using the prevention model. Risk factor prevention, physician burnout requires a concentrated effort by all invested parties. This involves you, the person involved, the organization, and the community. It is often pointed out that it should be also in a national level. This is to improve the structure and organization of culture of healthcare. Specific interventions may be conceptualized as risk factors in reducing. Specific interventions may be conceptualized. This is by means of the occupational health prevention model. In an individualistic approach, we must look in the lens of a lifestyle specialist. Our 6 pillars of lifestyle medicine are there for us to guide our patients, including ourselves, in managing burnout. So we look at these 6 pillars: management of stress, avoiding risky substances like alcohol and cigarettes, healthful eating habits, increase in physical activity, improved sleep, and formation and maintenance of a healthy relationship. To tackle the management of burnout, occupational health prevention models provide us with 3 levels. However, we want to add another 4th by means of the primordial prevention. Primordial prevention strategies is to avoid the risk factors before they begin to affect the individual. It is a concept first introduced in 2010 by the American Heart Association with regards to the impact of heart disease. In lifestyle medicine, incorporating the 6 pillars effectively improves the overall physical and mental health. Through the 6 pillars of lifestyle medicine, we can focus on the individual approach for management of burnout. For a maintenance of a healthy relationship, we should engage in social support by maintaining healthy relationships and decreasing social isolation and loneliness. Managing your own personal factors, especially in the use of substance, healthy eating habits, sleep, and physical activities are also important for you to focus on whenever you feel you're burnt out. Finally, in managing stress, we must also involve ourselves in self-care, meditation, mindfulness, and social connections. Moving on to the formal occupational health prevention models, we have systemic and individual-based primary interventions. So the vision focused on human aspect care. For a system-based, it involves promoting organizational change. The vision focused on human aspect care and promoting empathy and compassion. Physicians may be able to derive their enhanced meaning from their own work. So the 6 major goals in primary intervention, system-based, include create positive work environments, create positive learning environments, reduce administrative burdens, enable technology solutions, provide support to clinicians and learners, and invest in research. Whereas for individual-based, it is often similar with the primordial prevention section that was discussed earlier. Focus on reducing the effect of burnout after it already has been noted by a physician. Many interventions can be done in the workplace, especially with regards to the 6 pillars of lifestyle medicine. The goal is early detection before the symptoms negatively affect the individual and the people around him or her. Developing an ongoing screening program using a validated approach is also important. Once a patient screens positive for burnout, more open and healthy culture of professional well-being can be addressed moving forward. Stress management programs are often important in an organization. To incorporate a coping and mitigating effect for stress among workers in their organization. Similar with the secondary prevention, as mentioned, tertiary prevention, it minimizes the adverse consequence of an established ongoing condition. It is inevitable that some physicians will truly slip towards the cracks, eventually developing a full-blown burnout. Let us ensure that proper resources must be given to patients with burnout, including employees assistance program and potentially other referrals. In tertiary prevention, we should also take note of nutrition. A healthy diet is associated with a lower incidence of depression. Adherence to a Mediterranean diet reduces the risk of depression for about 27 to 32%. Lifestyle factors that influence the gut microbe has already been studied These factors include stress, dietary intake, and dietary inflammatory index. Link between gut microbiomes and depression and anxiety show improvement with the use of probiotics. Exercise is also a key intervention for patients with burnout. It ameliorates depression and anxiety. Mood, it affects mood states and the feeling of sadness and anxiety. It increases the gray and white matter with aerobic exercise. Neurogenesis in the hippocampus is also being observed, especially in patients who are undergoing aerobic exercises. Finally, tobacco. Tobacco prevention or smoking cessation. Tobacco is associated with increased risk of depression and anxiety. So we must fully advise that patients with burnout must not dwell with substances such as tobacco. Smoking increases the prospective risk of depression in the near future. Now, what is the next step? What is the next step? The role of lifestyle medicine offers physicians to find joy and meaning to their profession again. Physicians are busy at work. There can be a misalignment of caregiver values in the current healthcare system. But our take home for this is we must practice our core pillars to provide self-care and later quality patient care. Thank you.